go quickly over this, but this slide I showed on Monday. But this is the current classification for ABMR, where you also have the molecular microscope equal to category 2 and 3 of AMR, and we discussed, or actually I presented last Monday, that this is likely not correct because the molecules are reflecting the histology very closely and are not reflecting the C4D status and are also not reflecting the DSA. So the idea on Monday was to actually try to equal the molecular microscope to the first two histological criteria, so MVI and the other lesions of Banff, but not the third one. And the third one should be the cause of the problem, as I think Olivier just said. So we really have to distinguish the histological picture that we can describe, that we also can measure using all the morphometries that we can see with the molecular microscope from the causes. This is different. And yeah, I think this slide has been shown too often. All credits go to Jasper Calame, by the way. He invented this thing. And yeah, there's no doubt that we are with the Banff 2017 classification not diagnosing anymore quite a lot of cases in many centers that we have seen. It ranges from 30 to 50% of cases in the centers of microvascular inflammation, according to the first two criteria of Banff, that we do not see DSA, and we can of course restart our discussions of why we don't see the DSA. Well, what happened is that this leads to the elimination of a category that has impact on outcome. So if you look at Banff 2001, the suspicious category reaching two of the three criteria had equal bad outcome as the three criteria, but of course this included many cases that had C4D negative AMR. So if you put the C4D negative AMR into the full AMR cases, you see that you have three distinct groups. So the negative for AMR without any of, so not reaching two of the three criteria, suspicious for AMR reaching two of the three criteria is intermediate, and then the three criteria is of course the highest risk for graft failure. And in Banff 2017 we eliminated a group of patients that we actually likely need to diagnose. And why would we like to diagnose it is because it's frequent, and this is the list of papers I found that published not only the prevalence but also the association with outcome. We discussed the molecular microscope, we discussed the relation with non-HLA antibodies, with missing self, and there is, as Louis has said, there's a lot of potential to look into this field, but we only have data from very few centers, so we really have to know what is the impact of that. We have data that show that it's even related to HLA mismatches in the absence of antibodies. There's biomarkers that are being tried for this phenotype. So there is a lot of research ongoing, as we have heard at this meeting. And the problem is that all of these papers are using different criteria for the definition. And if one thing, in my opinion, is important in Banff is that we need to have a clear definition if we want to all study the same phenotype. And that's why I would think that we need to reinstall the phenotype of DSA negative microvascular inflammation into the system. And I think it was yesterday or the day before that Brian suggested, yeah, we should again go back to the two of the three criteria, the previous definition. But yeah, we have to discuss that, but I would not do that, because the problem with two of the three criteria is that you have a mixed bag of patients, and it's again not entirely crisp what you are looking at. So my proposal, and it's just a proposal, is that we have, of course, the HLA-DSA positive AMR cases. This is what we just discussed. The C4D positive DSA negative cases, yeah, we had the suggestion by Ian that C4D could also be related to ischemia perfusion injury. I personally, I don't know how strong, how important it is to keep it equal to DSA or not. But what is, in my opinion, important is that we define HLA-DSA negative microvascular inflammation, and actually also agree, and I think this afternoon we have heard that both the non-HLA antibody field, the NK cell field, that we don't know the underlying pathophysiology and the vast majority of the cases, so that we just put it in the classification not as a phenotype of rejection or something that needs to be treated aggressively with all kind of things, but that we say cause unclear. And a clinician who gets the message cause unclear, of course, can then start treating with plasmapheresis, IVIG, and all kind of treatments to just try to improve it, especially if it's an indication biopsy and you have to rescue your patient. You can do whatever you want. But if you get that message in a protocol biopsy cause unclear, I would not dare to give all kind of antibody targeting therapies if I really have no proof of circulating antibodies. Another issue, and this is what I think Anna showed us very nicely, is that we need to be careful that HLA-DSA negative needs to be considered carefully, because it's not easy for even the specialist in the field to state it's positive or negative. So you should be very careful when you hear cause unclear to go back to the HLA lab and say, yeah, are you sure that there is no HLA-DSA? Can you look further into this? So this is a phenotype we need to investigate not only in research but also clinically, in my opinion. I could also even go a step further in the sense that you could say all of these phenotypes or microvascular inflammation, and then you have underneath that the next layer, which is representing the cause. And now we have a clear cause, which is HLA-DSA. And in the future, it might be that we have other causes, as Olivier said. It is even possible that you have multiple causes in the same patient. You have, we have here seen presentations where you see that I think Carmen showed that you have 81R antibodies that are co-active with DSA. Well, then you have two causes in the same patient. Likely you want to show the causes as an underlying factor, but that the main denominator is the microvascular inflammation that you see in all. So this was my presentation. I think I just summarized most of the things we have been hearing, and I prepared a few questions. I don't know if we first have some discussion and then we go to the questions, or we do first the questions and then the discussion. It's up to you. First the questions. Discussion, sorry.
So, I mean, I guess I agree with you, not necessarily to go back to the 2 out of 3 suspicious, but Lynn mentioned that there was a category in Banff 2013, C4D positive without evidence of antibody-mediated rejection. That might be eliminatable because it's something we see only very rarely and mostly in ABO incompatibles, and I think people now recognize that that's something we see in ABO incompatibles, not so much in 2013. But perhaps there might be a category that is microvascular inflammation in the absence of detectable DSA. Yeah.
I agree with you, but the category that Lynn is referring to actually is not microvascular inflammation. So HLA-DSA positive with C4D staining, earlier transplantation, highly sensitized DSA positive cases. You need to diagnose them.
Yeah, I was referring though to these cases where you have microvascular inflammation due to either non-HLA antibodies that haven't been detected, missing self, or some other mechanism. I think it needs to be acknowledged. I would be against calling it quote-unquote suspicious for antibody-mediated rejection, but I think it should be acknowledged that it is a category that has the potential to lead to a decline in growth.
Mark, I just want to make a point. This is great, but this has to be then accumulated over time. When I'm looking at a biopsy, they may not have the DSA, and then when I find all of this microvascular inflammation, then they will get a DSA, and then it'll be negative, and then depending upon suspicion, then they will look for non-HLA antibodies. So it's only some weeks later that this will be piecemeal, can be put together to say microvascular inflammation without detectable DSA. So I think that it's important how we word it, and the pathology acknowledges that we may not have all the information. At least in my place, most often the DSA isn't back at the time they're doing the indication biopsy. So to give wording that is not too strong and not too weak, I think is important. And then I think perhaps even there could be a mechanism, of course we should talk together, and then to have an integrated addendum to the biopsy in view of additional lab testing. This is now classified as microvascular inflammation without detectable DSA, and maybe we pathologists could be the caretakers of a next level addendum if we can communicate and get that follow-up information. Now, of course, on all of the outside biopsies we have, that would be difficult, but those who are in the same place, maybe we could do something. But we can't do that at the time we have the biopsy because we don't have the information.
Okay, well, I have an admission of guilt, and that is that if I have microvascular inflammation, C40 negative, and there's no DSA data available, I still call this suspicious DSA testing recommended. Now, if the DSA are negative, I go according to
Yes, but you don't have that. So this category of microvascular inflammation, the absence of detectable DSA, is something that has to be accumulated over time after integration of all information, not something that we can do at the time of the biopsy. We revisit, we do integrated communications, and it doesn't help. You can't have that as an initial biopsy diagnosis.
Would that then make sense to really start with calling it microvascular inflammation with a differential diagnosis that it can be HLA-DSA positive or HLA-DSA negative, and so that avoids you that you have to already.
But you're good, and then the C4D, right? Because if you have the microvascular inflammation with C4D, then we think for the most part that's pretty easy, right? Unless there's something.
So coming back to what we discussed earlier, maybe we asked clinicians how they understand before we jump the gun how we report it. Not that we may put the working out of work to do another survey, confirming that the communication is breaking down. So I think we can't solve it. I think conceptually what you propose is what the data we reviewed today supports. We know that microcirculation inflammation can be for numerous reasons. As always said, ideally we will be able to give the mechanism behind in the report, because we heard earlier that would allow to guide targeted treatment. We can't do this yet, but your proposal sets it up for this. So, but I think we need to engage a larger clinical community, because this is a dogma shift. We condition our clinicians, you see glomerulitis, that's very likely ABMR, and they can only see microcirculation inflammation and put it all in one box. So,
but it is still very likely ABMR, so they should at least search for.
But how does the communication not get lost if it is something else?
So
and we need to ask the broader clinical community about how this resonates.
So I just want to go back to comments we had the first day of the meeting. We pathologists, we, both men and women and those who identify differently, we are all physicians. And we
I use the term clinician.
We are all physicians, and we also are dealing with clinical responsibility when we're looking at the biopsy. And I do think that it is important to be clear, but it's also part of our job to interpret things. We shouldn't be putting things out in something like a Rosetta Stone code. So I'll give you an example. If I gave you a biopsy report that said focal endocapillary hypercellularity, focal double contours of glomerular basement membrane, focal arteriolar hyalinosis, focal eosinophilic material in the mesangium, immunofluorescence positive. If I gave you a list of 15 things and said, okay, I have told you all of the lesions. Now you go and figure it out. Instead of me telling you that it is focal lupus nephritis and telling the activity and chronicity, because I've interpreted all of it together. No, I'm not saying that you propose that, if I may finish. So I'm just saying that we shouldn't just list the lesion and then say, you go figure it out and figure out what it means. I think that we should, as far as we can within the data, give the likely interpretation of the lesion, and not just list the lesions. I'm not in favor of just saying microvascular inflammation or glomerulitis or peritubular capillaritis. You go figure it out. That maybe if we have limited data, be all that we're able to do a descriptive lesion sign out if we don't have full data, and then give an interpretation of it. But I do not think that we should just list lesions and then wash our hands, because that's our job. And I don't think anybody's saying that we should do that.
The patient deserves a diagnosis.
But sometimes we can't render it.
Well,
Yes,
a diagnosis
so
sometimes
patient
makes a
deserves a
solution.
diagnosis, but the pathologist deserves the information necessary to make the diagnosis. So that if I, as a pathologist, see a biopsy with microvascular inflammation, and all I have is, as a diagnosis, is kidney transplant upward arrow CR. That's
I told you it was a transplant, Mark, that's it.
so, I mean, but if I'm told, highly sensitized patient, if I'm told positive DSA, if I'm told negative DSA.
I'm not saying the pathologist
so yeah, it has to be a joint effort.
So I think we can learn a lot from the oncology field actually. There's a very nice WHO from neuropathology. They start with the integrated diagnosis, then they list the histological diagnosis, the grade, so that's the activity, currency doesn't make sense in the tumor. And then they have the molecular pathways that determine that the underlying process that led to that diagnosis. And that's the one that you want to treat. So I think that integrated diagnosis could also be very well fitting here. So I think we can look at actually what you propose. So
Can I have that? We may have, that's as been said before, that we may have to deal with different patients with several diagnoses. It has been said that the NK cells are negative by missing cells to antibodies.
Yeah.
And so you need to be flexible in the way that you give information. But you cannot expect that all patients will go in a single dose. That's not going to happen.
And also you can add molecular information in a later time point. So yeah, I think that's very well.
You're emphasizing when you use that example, tumor diagnosis.
Yeah.
When they do all that. When you get into things like demyelinating diseases, they're just like renal biopsies with a lot of scarring and people trying to piece out the etiology.
But there you also want to know what you want to treat. You have to treat the underlying disease, not the lesions.
Plus the other two,
So I think the term DSA negative microvascular information is a better alternative than saying DSA negative ABMR or suspicious for ABMR, so I like that. And in most big centers, DSA, if not available at the time of biopsy, can be had within 2 or 3 days. And that's not a long time to wait. And of course, you can adjudicate it later. That's also acceptable. The other thing I want to bring out is that earlier versions of Banff have been heavily influenced by the observation that the C4D is a very good surrogate for DSA. So if we have to have a term, DSA negative microvascular inflammation, we also have to make it C4D negative, DSA negative microvascular inflammation, otherwise we are in a zoo. And I wanted to ask Naesens, Maarten, since you have reviewed the literature so well, and you really believe, and I agree, that the DSA negative ABMR has a distinct prognosis. So what's your view of DSA negative C4D positive versus C4D negative ABMRs? Where would you put those?
C4D positive, DSA negative, you mean?
No, in the DSA negative, you have 2 categories. C4D
Yeah,
positive and C4D negative. So where do they?
This is the box that I colored in orange
That's
and
an
blue.
incidence box. Where do they go in the
It's very heterogeneous.
We learned today you can have microcirculation inflammation without rejection. Ian showed us the cases. So microcirculation inflammation cannot equal rejection.
It is a clinical, so the question is, how do you treat it as a clinician? And as a clinician, I don't know if I can speak for everybody, but it is difficult. And again, if you have a case that is doing badly, where you really suspect that something is going on, you likely want to treat with antibody treatment. But if you have really no clue and it is a protocol biopsy and the patient is doing well, and yeah, you would hesitate to treat because you actually, I would call it cause unclear then. And if it's C4D positive, of course the likelihood that it is antibody mediated is higher, but the problem in clinics is that I tend to not start treatment when I do not have any idea when to stop the treatment. And if you have a case where you would say there is C4D positivity, but the patient is doing very, very well. He has microvascular inflammation, imagine G1, PTC1, and this is MVI equal to 2. If you get that back and you have a patient sitting in front of you and you have to explain, you have to come to me every 2 days for plasmapheresis, I give IVIG, and you cannot expect that the kidney function will improve. You can of course hope that the biopsy, and you can do repeat biopsies, but with most patients, I would just say we wait until something happens. It's also clinical. We have not the slightest clue of evidence how this can end. And so we are a bit conservative. In other cases, we are much more aggressive. And I believe that by denominating this, we denominate something that actually, we are discussing something that we are currently even not diagnosing, at least according to the classification. Yes, of course.
Thanks. So the way that I learned the AMR classification and the way that I teach it to my residents is that it is a mechanistic diagnosis. So you have antibody in the circulation, donor-specific antibody in the circulation, it's interacting with the graft and it's causing injury. And it seems that those categories were flexible and they were open, and there were gaps in them, and slowly over time we did fill some of them and we haven't filled some of the others. And we're moving to a situation where there's less uncertainty, but it seems to be more a descriptive diagnosis. And my concern is that we move away from a mechanistic-based diagnosis, when, whereas pathologists, we're supposed to be diagnosing the pathophysiology of the disease, is a little bit worrisome. And I would just say that if we do so that it's based on a better understanding of the mechanism or overwhelming clinical data.
Thank you. If I may respond to that, I think it's very clear that we have to be mechanistic, but we also have to be honest when we don't know what is happening. And we'll only be able to close that gap of knowledge if we acknowledge it. And I would like to draw a parallel with the field of cardiology. So a couple of years ago, you had an update again of the ESC guidelines, and now this had this new category of heart failure. You had HF with a mildly reduced ejection fraction. That was ejection fraction 40 to 50. And it was met with a lot of criticism because clinicians didn't know what to do. It was these intermediate cases. But what happened was that studies started to originate on what exactly these patients were, which treatments you could give to them. And I think this is what we need to do in these patients who don't have antibodies, but they have MVI. I think we need to know more, and that could be helped by a new category in the Banff classification.
Can I make a comment directly related to that? That's exactly what happened. It was based on the missing cell story that start very small and get confirmed by others. We have no data that I haven't time to publish yet, demonstrating that if you shift the immunosuppression of this patient, these ones, not the one in particular, is the one with missing cell story, you may change the problem. So that's exactly what happened. By opening this category, you allow us, clinicians, researchers, to do something for them. If you continue to call them suspicious for a year now, while we know that there is no antibody around, you just kill the thing. I agree with that.
Yeah.
Yeah, I think that was the point.
Well, I think that's a good point. I mean, should we call something antibody mediated?
But there is
no evidence for antibody. There's no HLA-DSA. There's no non-HLA-DSA, and if there's not even C4D, then you don't call it
There is
antibody.
another mechanism other than that.
Yeah.
No, it's not more so.
Microvascular rejection.
think we should not.
Microvascular inflammation.
Yeah,
You've
we
got
should not
enough
talk.
there.
I think it's
I guess there's not only one lesion, microvascular inflammation, but there are also other features like TMA. What would you suggest how to include it in the scheme? Another point is we have seen ABNR cases which are MVI negative, but they then molecular score.
this is an extremely important discussion, because I think until now the question is, do we want to diagnose it, yes or no? And I hear a lot of voices saying, okay, we have to at least classify it. The question is then, how do you classify it? How do you define MVI? And I see that Agnes says that we do not want to have it defined just as the lesion scores. And this is discussion we need to have, and I think that Gerard is pointing to that. Is it just the lesion scores that we report? And I would be hesitant as to do that, because we have already a long discussion on how MVI and APMR histology looks like.
Let me ask Agnes a question. I think an analogous situation. So you get a biopsy from a patient outside, and you have very little information on the patient, and you look at the biopsy under the microscope, and you see nodular glomerulosclerosis. And you do the EM, and you have thickened GBMs, and the immunofluorescence doesn't show any specific findings. 98 out of 100 times, that's diabetic nephropathy. But without the information that the patient has diabetes, would you call this diabetic nephropathy?
No, and this happens. So I call that nodular glomerulosclerosis, and in a comment I say it has this and this and this. And the most common cause of this is diabetic nephropathy. There's no history of the patient being diabetic. If the patient is not diabetic, I rule out all of these other things, and this could be idiopathic nodular sclerosis. And I call the clinician, I say, this looks like diabetes. Oh no, Agnes, he's not diabetic. And I said, but is he maybe obese, obesity? And from my Louisiana clinicians that I deal with, just a couple months ago, they say, oh, let me look. Oh no, he's not that big. His BMI is just 32. So then
exactly.
Yeah, exactly. No, I agree.
Exactly.
So I think I was talking in general, but I don't think that we should devolve to just giving lesions for everything. I think
not for everything, but when you don't have enough information. Sorry.
So I think that when we do not know the cause, and we don't have the history, we don't have the DSA, we just have microvascular inflammation, then I think we should do, as I was trying to say earlier, then we just do a descriptive lesion. And then we do an interpretation below. There is no, the patient's DSA is negative. This could be a non-HLA antibody. The C4D is negative. We don't have any other inflammation. There are many other causes of this. This is in the differential. We do that all the time. But I don't sign out all of my biopsies just as a lesion listing. And I know some pathologists, some people at the AFIP would do that. They would list all of the lesions and then say, here, I've given you all of the stuff. You go figure it out. But I do think in cases where we either don't get the history, or the tests haven't been ordered, or there's more digging needed, that we need to just give the lesion and give our interpretation of possibilities. And then I was suggesting that maybe we could have teamwork so that that biopsy could have an addendum to it with more testing being done. Just like I send out mass spectrometry on weird amyloid cases, right? I don't know what it is, and then I do an addendum. Oh, this is weird amyloid type such and such, right? I think we could have a similar way as something to aim for.
But the histology is one thing, and then the diagnosis is another thing. And
yeah, but sometimes we can absolutely make a diagnosis, right? A specific diagnosis. Yeah. I can make a specific diagnosis of light chain deposition disease in another case of nodular sclerosis, or I can make a specific diagnosis of diabetic nephropathy, and sometimes I can just describe the lesion and give a differential.
Which is exactly what I was trying to say. Where you can.
Yeah.
What you're saying is very good for day-to-day clinical practice, but we are trying to collect registry data, conduct clinical trials, and then it's nice to have a category in which these biopsies are put so they can be ready to treat and study.
But the thing is, for a clinical trial, I don't think you really can enter people who can't, that you are lacking information, can't put them into something. So the cases that Ian had, I don't think they could be, oh, they had lots of microvascular inflammation. They can't be put into a clinical trial.
No, but discovery reports cannot be tracked or studied as a national basis.
They absolutely can. We store them and rate them.
Yeah, if you can give a diagnosis, you do give a diagnosis. If you can't give a diagnosis, then you have to have a description category,
Yes.
like nodular glomerular
Exactly.
sclerosis,
Exactly.
and a comment, testing for latent diabetes is advised,
Yeah.
or
Or
whatever.
obvious diabetes that is just.
Right. Yeah.
So in that sense, Maarten doesn't get you qualified. Just call it HLA negative microvascular inflammation. You comment, put whatever you want.
But you don't know always that it's HLA negative. You might be HLA
Yeah,
and be missing.
Yeah, you can, fine tune the wording. The concept is good.
But so the question is, do we stick with the pure histological lesion scores? And this is indeed the definition that you could consider, and that Agnes is a bit afraid of, and I would also be afraid of that kind of this definition, because it's simplifying, oversimplifying many years of discussion of where are the thresholds. And I know, for instance, in the Nature Communications paper, Olivier, you have used the first definition. And in all our studies in Leuven, we have used the second definition, ABMRH, which we would hate, but that was at that time the only way we could describe the histology of ABMR. That's the abbreviation that we used, with all the tiny, let's say, footnotes that are in the current Banff classification for ABMR. And the question is, do you want to keep all these footnotes also for microvascular inflammation in the absence of DSA? I'm not sure. Third option could be the option that actually Candice has discussed yesterday in the session on clinical trials. There is a paper, a full paper on how she comes to that kind of proposal, where you actually take into account those factors that are quite robust within the current Banff classification. And we looked into that in Leuven to see how much is the overlap between the different definitions, and actually it's 97% overlap. So it does not matter too much which of these two you use. And I agree with Georg that if you have TMA, okay, this is difficult, but if you have TMA without anything else, would you call it MVI and start? I would be a bit hesitant. It's
TMA.
You call it TMA indeed.
In a national paper, it's relevant the definition of studies that we use, because in fact, we did not take into account the BTC2 in the CMR methodology. It was close to what Candice was proposed. I think that's the third proposal is probably the most operational.
So my issue.
But the question is, why should we only concentrate on microvascular inflammation? We would have exactly the same problems with endarteritis that may be also a manifestation of ABMR, but a mixed rejection. And as Bill said, with TMA, why should we only concentrate? We would have exactly the same problem, because there's such a huge overlap, which we don't need to prove for endarteritis and TMA, and has been shown for
I think the answer to your question is because you can diagnose with the current Banff classification ABMR only with microvascular inflammation, but not solely with the deep lesion.
Yeah, exactly. So
you still need microcirculation inflammation.
Yes. So you're talking about.
That's the difference.
Yeah, you're talking about the difference in these 3%. So there's 97% overlap between the third and the second, let's say, definition of MVI. So you have very rare cases where you have indeed V and some, ATN, for instance, in the biopsy, where you would say, and then there's only, so we have listed what is this 3%, but it means that you need to have 100 biopsies with unexplained microvascular inflammation to find one of them that is a little bit, or three of them that are a little bit outside of this kind of definition. So my personal proposal would be to keep it as simple as possible, not too simple. I think the top one, just adding the lesions is not wise. The second one could be used because it's then fully aligning with the current DSA positive ABMR classification, but the third one, it does not have footnotes.
But how do you reconcile the second version with being DSA negative and microcirculation inflammation? Because you call it antibody-mediated rejection, but that comes to Mark saying antibody negative, DSA negative, antibody-mediated rejection.
But I would not use it. So for our clarity,
Denise Watts will be screaming at us.
So
I can hear it.
So Michael, I would certainly not. So I think we are here discussing the concept of how you define it with the lesions and the histological picture. We are not discussing the name of it. I think who said this afternoon, I think Louis suggested to get rid of DSA negative antibody, so antibody negative, antibody mediated, this is not possible. So the ABMRH is just because that was the definition that we use, but it's certainly not the one that we should use for this phenotype in my opinion.
So I sort of like the idea that you have as kind of, I mean, I don't think microvascular inflammation DSA negative should be a specific category either, because a lot of times you have microvascular inflammation and you don't, and the DSA hasn't even been done. So you can call it microvascular inflammation, further definition needed, and then all you need are 2 footnotes. Footnote 1, testing for anti-HLA-DSA is needed. Number 2, if anti-HLA-DSA are negative, then this is your differential. Non-HLA antibodies, missing self, etc.
And the footnotes should be feet smaller than Sasquatch. That's the abominable snowman.
So you don't need all the footnotes we had in 2013, just 2.
Yes. Like running a marathon.
Yeah. It's good. A few beers and.
So regarding the 3 options, I see a particular conceptual problem in the second one. In view of just I said, in the past, C4D positivity has been taken as a surrogate for DSA.
I think it still should be.
So I cannot accept the second option. It has to be number 3 in my opinion. And also I want to ask you why there is 97% overlap when there are 20 to 40% C4D positive cases in the second definition. So that doesn't strike to me as intuitive.
I mean, C4D would still be a surrogate marker. So you'd still have that. So if you have no DSA but C4D, that would still fall under the ABMR category. I don't think that should be moved. I think the third category should apply exclusively to where you have microvascular inflammation, C4D negative, and DSA is either negative or unknown.
That's what I'm saying. It should be C4D negative.
Yes. Yeah. And so that would solve the issue of the bar, which I don't know what to do with. I think that we should not change it too much, and in 2017 you moved the C4D positive, say negative cases into the ABMR group, and that is not that much contested. We have not seen any study that contests that concept.
And you should relook at that.
And then it's easy because then you have a very much crisper definition of the HLA-DSA negative, C4D negative MVI.
Just relook into that 97% overlap. I suspect
Yes.
something.
I think the only thing that's really wrong with 2017, as far as ABM, is the inclusion of the classifiers as a surrogate marker for DSA. I think that needs to be expunged. What we didn't know, though, in 2017, and the knowledge has accelerated exponentially in the last 5 years, we didn't know about all of these cases of microvascular inflammation with no detectable DSA. I mean, that in 2017, we saw those cases, but I viewed those as a red herring back in 2017. Now we're seeing that they account for 30% or more of cases where there's MVI greater than equal to 2 without C4D. So I think that we're just like back in 2005, we saw cases that had microvascular inflammation and DSA, but without C4D, and we thought of those as a bit of a red herring. But they became more evident over time, and then there were some nice publications specifying them from Alex and Banu. And I think we're dealing with the same situation here. In 2017, that might have been a bit of a red herring, but now we're seeing how frequently, a phenotype this is, and we have to deal with it.
this happens a lot. When you have a test or a finding that is very useful, you begin to apply it more and more broadly. And then you find out that it's more heterogeneous and there are things that aren't quite fitting with that. Think about ENCA. Wasn't that a perfect test when it first came out? But it's not. Not all cases that clearly have ENCA-related disease are ENCA positive. And vice versa. Not all people with ENCA have disease. So we're going to see when we do a test or a phenotype and try to apply it broadly across that there are going to be bigger and bigger categories that don't meet our preconceived boxes.
Yeah, so I'll bring it back to diagnosis as an ABCD where you have a disease and it doesn't have all of the components. And we see that in general medicine. You know, when you get your COVID, you may have a little bit of a sore throat, but you may not have the cough or whatever. So you won't have all the symptoms. So what we're dealing with antibodies, we've got a disease and we're using components. And two of the components are DSA and the C4D have got sensitivities and specificities. Right? So they're sort of tests within a test and they are not perfect. So we've had DSAs where we had a virtual cross-match, looked okay, early antibody-mediated rejection, no antibody at the time of biopsy, but 4 days before, yes, there was an antibody at the time of transplantation. It just got sucked in. Or we've had another one where the DSA, the lab screen was negative. We had a B-cell positive cross-match, terrible antibody-mediated rejection, went to transplant, DSA was negative, did it again, and then we found it was a DP. It wasn't on the chip. It wasn't on the screen. So we have a test that's telling us that it's negative. So it's a false negative. So all of these components have got false negatives. So we have to be able to deal with that. The fact that it's going to be incomplete and how we deal with partial phenotypes, incomplete phenotypes.
This approach allows us to learn. We see the pathology, we take those out, we know it's HLA induced, and then when we routinely look for missing cells, you make the orange bar smaller over time. But I think this structure sets us up to exactly deconvolute how Agnes says this basket of
and the incomplete phenotypes you're talking about, if I think about them, it would be like isolated glomerulitis without anything else, like PTC1 without anything else, TMA without anything else.
One component. But if we had, say, two components, so MVI. Right, so just think about this. MVI with C4D, that would be suspicious of antibody. MVI, C4D negative, but you've got a DSA. That would be suspicious. C4D, so no MVI, but you've got a positive C4D, and you've got an MFI antibody of a few thousand. That would be concerning. So you don't have, maybe I've given them steroids and the cells have gone away. Would that be suspicious?
I would think so, yes. It is the category that we currently also have in the Banff classification, which was shown as a C4D DSA positive group. That this is indeed suspicious for DSA positive ABMR. It's a bit a different discussion, in my opinion.
So do you think we're actually underdiagnosing with our current system? Are we missing antibody-mediated rejection? If you look at that. So some of those ones that were called in 01 and 13, yeah, we lost a lot. We lost a lot with 17. And I've got a feeling there's a lot of antibody-mediated rejection that we're not being able to call.
Exactly.
I think Brian is making an important point. In practice, clinicians are using suspicious for ABMR, so we should consider having an official recognition that there are cases, and we can think about what to put in it.
But if this is in HLA-DSA negative context, we are talking about almost isolated lesions. If it is in a DSA positive context, I would indeed be completely different. And we have that category, it's C4D positivity in the context of DSA. It is currently already in the Banff classification, and it is also considered as not entirely clear. Is this rejection, yes or no? And I really have no idea whether clinicians are treating this. We don't.
Mark, up here, in the very back here, somebody who's been waving their hands. Versus the waving their
As I'm running around, some people are getting tired with their hands.
Very tired. I think we can, or I've taken a lot from Ian's discussion. There's at least
three etiologies for MVI. There are probably more we don't know about. And if I have a case of MVI and there's 5% questionable borderline, I inbox for CD68 and CD3, and you see a lot of CD3 capillaritis. So you've got a wimpy borderline and there's capillaritis in CD3, there's no HLA, C4D is negative, then maybe it's just a funny low-grade case of T-cell rejection that's not otherwise classifiable. So should we be doing CD68 and CD3 and all these MVIs where we have no idea what the etiology is? We can at least possibly exclude one. So that's my experience.
I fully agree. When you diagnose it, people like you will start staining and see whether macrophages, when stains, that helps or not. And maybe it helps, and then in a few years we include it because it helps. But yeah, this is exactly the idea of including it and defining it.
In a lot of your data with the MVI that has bad all your data with the MVI that has bad prognosis, suppose half of those the capillaritis is CD3, and you've got a simmering T-cell rejection that's not above some cutoff, but is chewing away at the kidney.
I fully agree, and then this group is likely very heterogeneous in etiology and also in the type of cells that are infiltrating. Ian showed that beautifully, how the different types of cells are actually likely related to pathophysiology.
I don't know whether it would be really helpful, because it seems to be that, and probably it's the reason why the molecular classifier are not working very well, you have different triggers that are important for clinicians to select a treatment, but it ends up in the final common pathways where it looks really much the same. In the NatureCom paper, there is a supplemental figure where we have used a computerized automated way of counting the cells in different compartments. And if you compare the patient that have an AMR with a DSA and an MVI to the one that have MVI without DSA and are supposedly due to missing cells, the composition of is exactly the same. There are huge heterogeneity between the two groups, and you cannot distinguish one patient from another. It's very difficult. The only tiny difference seems to be that you have a slightly more NK cells, but it's really complicated at the individual level. I guess you wouldn't be able to classify the patient correctly.
Sorry for being so far away. I have a question to Maarten and Mark. After this discussion, what do you think is the place of molecular diagnostics now in this scheme? Is it a parallel diagnostic system?
With the available data, there is no space because they all just measure microcirculation inflammation. They're the same between the orange and the blue. So
yes.
We review the data.
Yes, so in my opinion, when you have microvascular inflammation histologically, in 85% of cases, the molecular microscope will confirm it. And in 15% of cases, it will be distinct. You can only look for the molecular microscope in those cases that are unclear in the TMA, C4D positive, MVI negative, and then you will be extremely disappointed because your molecular microscope will go in all directions. But the bottom line is that the molecular microscope in 85% of cases is congruent with the final diagnosis of the pathologist.
But I guess the situation which was discussed by Jan, the early biopsies with microcirculation inflammation, these are typically molecular microscope AMR score negative. And this would be helpful, just to discriminate the non-immunologic causes of MVI.
I guess the way I feel about the molecular microscope is I agree with Michael that it's picking up sort of the final common pathway of inflammation. It's not picking up an etiology of that inflammation. Now, admittedly, the molecular microscope does pick up some lesions earlier than routine histology, and it has some value in that regard. And it may also have some value in some equivocal lesions. But unfortunately, we put molecular criteria into the Banff classification 10 years ago, back in 9 years ago, back in 2013, and still the tests are, are only used in rare laboratories. And so I think it may be premature to have a molecular classification now until the use of the molecular microscope, be it MMDX or be it, nanostring, is a little bit more widely used. And in response to something that Brian said also, I don't think that classification should really include every potential lesion under the sun. So like I was going to ask Brian, he mentioned C4D positivity, anti-HLA-DSA, 0 MVI, G plus PTC 0. How often do we really see that? I wanted to do a study on that back in 2012. So I have a little piece of paper taped onto my microscope looking at such cases to try to list them to do a study. 10 years. I look at 1,000 biopsies a year, and I think I've got 6 cases. So that's a red herring.
Population dependent though. We have we have a big African American population, Middle Eastern, and Asian population. We do a lot of A2Bs, and we see it all the time. I would say so.
This is completely atypical, completely LBO compatible. So
this is A2Bs. We have this. We do a lot of A2Bs, and so that's for me a very common diagnosis.
Yeah, but in HLA compatible, we don't see.
Thank you so much. I think we had a great discussion, and the discussion is certainly not over. We have heard many voices, and I think it's very important that we listen to each other, that pathologists, nephrologists, not only us, but we take into account also how the end users will appreciate everything that we do. So in the next days, we have the opportunity to still discuss it amongst us, and next weeks and months to really try to get it on paper. Any other suggestions, of course, welcome. I think you can send them to Candice, to everybody in the room. Friday is a summary session, so we'll try to summarize what was discussed here. Thank you all.